Hello, my name is Christopher, and today I'll be presenting on propranolol. Um, yeah, so what am I trying to do? Pretty much what I'm trying to propose is that we use propranolol for psychiatric usage, and below I have a graphic outlining the sort of workflow to do this. So we need a lot of trials to do, we need a lot of literature review, we need a lot of um, analysis to happen to be able to repurpose this for the uses that I will propose. What is propranolol? Brand names: Hemangiol, Inderol, Inopren. Pretty much is a beta blocker used to treat hypertension, atrial fibrillation, angina, pretty much random chest pain, and then migraine can be used as a migraine medication as well. How does it do this? So it binds to beta adrenergic receptors, both of them. So we're going to talk about receptors 1 and receptors 2 throughout the myocardium and other smooth muscle, and acts as an antagonist. So beta 1 receptors, pretty much what they do is if they're activated, they will create more cyclic AMP, there'll be more calcium in the cell, and there's going to be more depolarization within those cells, usually in the myocardium, um, meaning more heart contraction. If you block this pathway, then you're pretty much reducing the heart contractions, meaning you're lowering heart rate. Therefore, you're reducing the workload on the heart, which is pretty much how it works with hypertension, AFib. These beta 2 receptors, activating these cause, again, more cyclic AMP, more protein kinase A, but then they cause less MLCK, leading to smooth muscle relaxation. So pretty much, in layman's terms, a vasodilator to a small degree, also helping with that angina and migraines. Um, and then right here, I have included the chemical structure for propranolol if you wish to examine it closely. So let's delve a little deeper. I've added a lot of stuff on here, pharmacokinetic stuff and dynamic stuff. So as far as absorption is concerned, there is a time to highest concentration in the bloodstream, Tmax, of 2 hours, and this can be demonstrated in the graph bottom right. Right. So if we look at our fed population, we see that there is a peak right here, right over the 2 hour mark. And then in our fasted population, it's sort of over here at the 3 hour mark. And this is because, being fasted, one means it's going to lower the bioavailability of that drug if taken orally. And two, it's going to shift it slightly. Other than that, um, really no main differences. Right, so in distribution, it has a volume of distribution of 4 liters per kg, pretty much meaning that it's going to get into that plasma, it's going to bind to those plasma-bound proteins, and it will sort of move into interstitial compartments, but not further beyond that. Um, and that's kind of just what we need for this medication to do. So its affinity to those plasma proteins is 90 to 95%, pretty much meaning that 90 to 95% of the administered dosage is going to bind to these plasma proteins, particularly alpha acid glycoproteins. And then the free drug is what's going to diffuse into those fatty compartments. And then I've opted to add a molecular weight in there as 259.34 grams per mole. We're going to talk about that later, as this allows it to be small enough to be able to cross the blood-brain barrier. As far as metabolism goes, it is first pass effect susceptible, meaning it's going to be metabolized, just excreted through a couple of factors. Largely, it'll be metabolized in the liver by a P450 enzyme, more specifically CYP2D6. This is going to be metabolized into 4 different metabolites here below in the bottom left. So pretty much what this enzyme does is it's membrane bound. It has a coenzyme that contains iron, and it will oxidize the molecule, rendering it useless. As far as elimination goes, there is a half-life of 3 to 6 hours, and it is mainly excreted in the urine. Again, we can see that in the graph. If we look at our fed exclusively, around 2 hours, and then we look at 3 hours later, which would be around the 5 hour mark right here, we see it is almost half of what it started out to be. So pretty much just factual. So back to repurposing it. How could it work? So I propose that it works via autonomic system suppression, so it can help with that vasodilation, that slowing heart rate, less sweating, less trembling, bronchodilation as well. So pretty much alleviating those physical symptoms of anxiety. So pretty much also beta adrenergic blockade. What do I mean by this? By blocking the beta receptors, it's pretty much going to block norepi and epinephrine as their role in the fight or fight response in our brains. So it can help ease the person of the physical symptoms of anxiety. And then right here at the left side, I have included a graphic. So here we have our beta blockers. We have norepi and epi getting released, trying to get in here, but it can't really do it as well, therefore stopping that fight or fight. And I added in here amygdala's helper, question mark, mainly because much of that stuff is theoretical, but pretty much what is proposed is that reactivity in the basolateral amygdala is reduced because of these beta blocking effects, suggesting that it may modulate and reduce emotional processing, and we'll get into that when we talk about PTSD. So what can we use it for? Anxiety. Why? Because it has already been done for performance anxiety, at least. So some signs and symptoms that can help alleviate those headaches, that sweating, those palpitations, so just those physical symptoms, propranolol can help alleviate. And since it lowers the basolateral activity by those beta blocking mechanisms that we talked about earlier, it can reduce the emotional susceptibility, and so pretty much preventing that stage fright or activating that fight or flight response. And so just so we're all on the same page, right here on the right, I've included a cross-section of the human brain. So right here in green, when we zoom in, I've chosen to highlight the basolateral amygdala for you so that we know what we're looking at. How can it do this? So it crosses the blood-brain barrier. So here's normal vessels, right? There's almost nothing blocking it. But here in the blood-brain barrier, we have endothelial cells sort of surrounding it, making it harder for molecules to sort of cross into there. But since the molecular weight is so small, smaller than 500 grams per mole, it's able to cross these little tight junctions and then into the brain to sort of block the adrenergic receptors over here in the basolateral amygdala. So, PTSD. So here, a lot of the research is very early and very theoretical. There's been conflicting evidence, at least when I was doing my research. There's been many different estimates of what happens here. But pretty much what a lot of people are proposing and what I propose is that the use of propranolol after a traumatic event or injury can help reduce the symptoms or prevent the development of PTSD altogether. And the underlying mechanism of this would be because we believe that these adrenergic receptors in the brain can help encode these traumatic events. So by blocking these receptors from activating, we're sort of blocking the encoding of this event from happening. So some clinical applications, so use after any sort of traumatic event in the ED or even in the ICU could potentially help. Obviously, continuing that from ED to ICU would be a sort of a research that needs to happen. However, one source states that propranolol acts to dissociate the state of sympathetic arousal from the recollection, so pretty much remembering what happened, but without the actual stress of the event. So just making it just a pure memory and not so much something that needs to be concerned. And so some limitations, side effects. Obviously, this is a very new field. We definitely need more trials to happen. Some side effects of propranolol, bradycardia, abdominal pain, nausea, vomiting, erectile dysfunction, wheezing, fatigue, and in severe cases, allergic reactions, insulin resistance, and hallucinations. And so the ethical dilemma coming in is that in order to really get some concrete, evidence, you gotta test these out on, on the anxiety side. It's much easier than it was to do for the post-traumatic people, right? Because then you need someone who's been through something traumatic, and that might be a difficult population to work with, especially considering where their morale may be at and other, family considerations. And obviously, the amount of money that this would take, it would be definitely a big ask. So looking forward, how can this be used with other drugs? So it can be used with SSRIs, benzodiazepines, or mood stabilizers like Valium. And so pretty much what propranolol, the role that it would play is reducing with the physical symptoms of it, while these other drugs can sort of hone in on the actual um, cognitive portions. But obviously, more work has to be done to be able to conclude its effectiveness within the psychiatric setting. But it's the evidence so far is pointing in the right direction that it could be used. Conclusion. So, is it possible? Maybe. And the reason why I say maybe is because it is already proven to be a very effective heart medication. So it's difficult for it to be repurposed within the psychiatric setting, given its overwhelming uses in the cardiac setting. However, that is not to mean that it cannot be used in a psychiatric setting. Is it always going to be better for cardiac? Probably yes. However, if there's more better evidence to support its use within psychiatry, then I can see this becoming a viable drug in the future. However, for now, a lot of this is theoretical, unfortunately. And so here I've listed some references, and I will be I'll be putting a link if you guys would like to download the slides and go through everything. I have some more information on the speaker notes. Please feel free to send any questions my way, and I'll be happy to answer them. Thank you so much for listening.